Well, thank you for joining us today. I think you've had 3 great lectures, and hopefully I will be able to follow suit. We're going to be talking about fracture healing in a talk that we like to call the alphabet soup of bone healing, as there are many facets to bone healing that we need to understand. So my name is Anatomic Reduction. I'm a professor of orthopedics down at the University of Texas Health Science Center in San Antonio. I've been in practice now for 23 years. I'm an orthopedic trauma surgeon, fellowship trained. I do mostly trauma, although I do have a big interest in both non-unions and malunions. So fracture healing is something I'm extremely interested in as a traumatologist, in having to deal with these fractures on a daily basis. I'm a consultant for these particular companies. So let's talk about learning objectives. First, we'll describe the fracture healing cascade. There are 3 phases that occur, and we'll go through each one of those. We'll talk about non-surgical options to treat fractures. And we'll also explore the biological mechanism of action for LIPUS, or low intensity pulsed ultrasound. We know that LIPUS can accelerate the stages of the fracture repair process, which we will go through, and you'll see how LIPUS stimulates each one of these particular stages. We'll also go through the decision making when we're looking at fracture treatment options. Obviously, we have both non-surgical and surgical options, and hopefully I can give you an overview of some options and how we decide which ones we should do, which obviously will take into consideration many factors. So let's start with bone. As you know, bone is a living tissue. It's comprised of 99% of our body calcium, and it's involved in both calcium phosphate metabolism as well as vitamin D metabolism. If you look on your far right, you can see the pathway where you have hydroxyvitamin D and how calcium and phosphate intermingle with that. And there are a significant number of hormones that are involved with bone metabolism. Parathyroid hormone, calcitonin, thyroid, growth hormone, and corticosteroids. I'm sure over the last several years, we have all become more in tune to vitamin D and the lack thereof in patients. Majority of my patients, especially that are being evaluated for non-unions, get vitamin D workup. And at this point, we get a vitamin D 25 hydroxy level, and oftentimes that will be extremely low. And despite patients being out in the sun, drinking milk, we're finding that many patients are vitamin D deficient. So this requires both vitamin D replacement as well as calcium replacement, since they both interact in terms of vitamin D metabolism. Additionally, we find that many of these patients will have secondary hyperparathyroidism because of the low vitamin D. And I would say we have an incidence of about 4 to 5% of those patients will have very elevated PTH, which fortunately resolve over time once you do the vitamin D replacement. In addition to metabolism, obviously bone is a mechanical structure that is very strong. It has high stiffness and high strength, but it only takes very little deformation for bone to break. This is just an example here of a tensile machine pulling a bone apart and resulting in fracture of that particular bone. So bone has been felt to be strong in compression, and that's attributable to its mineral phase, which comprises 60% of the bone. It has that calcium hydroxyapatite and calcium phosphate, which provides hardness and rigidity. And again, that's what provides the strength in compression. Although the organic extracellular matrix provides strength and tension, we know that bones themselves are weak in tension as well as torsion and easily fracture in both those mechanisms. But the organic matrix provides 40% of the overall volume. It's comprised of type 1 collagen, proteoglycans, non-collagenous proteins, and this is what provides the flexibility and resilience that bone has. Going on to bone healing. Realize that bone requires both a mechanical environment that is suitable for healing, as well as a biological environment. The mechanical environment is really what we are responsible for as a surgeon. And that also includes the way we stabilize the fracture non-operatively many times, whether that's cast application, brace application, and then obviously surgery. The biological environment is what the patient is responsible for. So that's the living pluripotential cells, both from a micro standpoint in terms of looking at the limb and the fracture site, but really having to take the entire patient into consideration. So bone healing is affected based upon how we fix or stabilize fracture. So depending upon how much motion occurs between fragments, you will get different types of bone healing. When we talk about stability, we like to talk about absolute versus relative stability. In absolute stability, we have really no motion. In relative stability, we want motion to get that fracture to heal. This results in two types of bone healing. With absolute stability, you get direct or primary bone healing. With relative stability, where there's motion at the fracture site, you get indirect or secondary bone healing. And that's kind of shown here. Absolute stability leads to primary bone healing, and relative stability leads to secondary bone healing. I like to look at indirect bone healing as really nature's way. It's the usual picture of bone healing, which you can see here. It's a fracture that healed with abundant callus formation. And this was done with relative stable fixation. And in this situation was an ulnar fracture treated closed. I think it's important to understand the 3 stages of fracture repair, which has been described well in the literature. So you have 3 phases: the inflammatory phase, which is 10%, the reparative phase, which is about 40%, and then the remodeling phase, which again is about 70%. The reparative phase is where you have angiogenesis and cartilage begins to form. There's cartilage calcification that occurs, which is then eventually removed and replaced by bone. The remodeling phase is the longest time, and that's really when we are comfortable that the fracture is healing and the bone will basically remodel. Obviously, in younger patients, there's more remodeling than occurs in older patients. When we look at these particular points of time, day 0 to 2 in the inflammatory phase is when the hemorrhage occurs from the original injury. You get necrosis of fracture edges, which you can see here in the schematic, and then in the histology slide on the right. During days 2 through 5, you have clot formation. There's neovascularization that occurs, inflammation, which allows for granulation tissue to occur. And you can see what that looks like in the histology on the far right as well, compared to this, where you have some hemorrhage and necrosis. You now get granulation tissue to form. By day 7, the clot starts to resolve. The granulation tissue begins to be replaced by cartilage. After a week to many months, you get osteoblasts that move from the periphery towards the center. And those are kind of shown there in blue in that schematic. And then you can see there's organization and resorption of the clot, and you get more callus form. And really you want that callus to bridge across the fracture site, which then eventually will solidify. So the remodeling phase takes over. And again, that occurs from weeks to months after the fracture. You get remodeling of the haversian canals, which again help with more blood supply to integrate into the fracture site. That woven bone remodels to lamellar bone, which you can really see in the microhistology slide there on your right, with that pink wavy stuff is the nice bone forming. And the original cortex is eventually restored. So if you look in summary in terms of secondary fracture healing, You get inflammation, which occurs immediately when the fracture occurs for about a week. Then you have soft callus formation, which then eventually is replaced by hard callus. And then there is remodeling that occurs. So examples of relative stable fixation, again, casting or splinting, external fixation, intermedullary nailing, and bridge plating. And we'll show some examples of those at the very end. Here's one example of indirect bone healing. You can see the injury of the left tibia on your left side there, and the eventual outcome after being treated with an intermedullary nail for the tibia, and really closed alignment or closed treatment of the fibula. And you can see callus formation or secondary bone healing occurred for both fracture sites with successful healing. This is in contrast to direct bone healing. When plates and screws are used, you get contact healing between the bones. You have rigid or absolute stability, resulting in no micromotion, hopefully, between the fracture fragments, and that will lead into internal remodeling and eventual healing. Here's another example of a forearm fracture that was treated with plate fixation. So the absolute stability you get comes from compression of the bone fragments, which can be achieved with lag screws, which are placed perpendicular to the fracture plane, providing direct compression across the fracture site, with addition of plates in neutralization mode to add and counteract the rotational forces on that bone. Plate fixation can also be used to provide direct compression, depending upon how the plate is applied when you have transverse fractures. So once you get anatomic reduction of the fracture, such as in this case of a humeral shaft fracture, you get absolute stability and you get leading of, or you get fracture healing via primary bone healing. And realize that the stiffness and strength increase as what units called osteons develop across the fracture line. Well, what is an osteon? An osteon unit is comprised of both osteoclasts and osteoblasts. And you can see the osteoclast at the very front edge of this, what we call cutting cone, which is drilling a tunnel into the bone, allowing osteoblasts to come in from behind to create or form new bone. This can be seen in the histology schematics here below. You can see that cutting cone going across the fracture site and then bone healing occurring. The cutting cones cross the fracture line, creating a new reversion system, which allows for blood vessels to infiltrate the area and help improve the bone healing. And again, this requires absolute stability or no motion between the fracture fragments. So in comparison, direct or primary bone healing requires anatomic reduction with rigid fixation, most often plate fixation, where there's no motion at the fracture site with very low or zero strain. There's no gap, because we know that bone does not like gap to occur or distraction of bone fragments. Because there's internal remodeling that occurs, there's no callus formation. In indirect or secondary bone healing, there is micromotion that occurs at the fracture site. So the strain is much higher, but it is usually distributed among fragments. So when we do relative plate or relative stability plate fixation, such as a bridge construct, we're bridging, if you will, all those comminuted fragments, and all those fragments have different strain and different motion, but the overall strain is distributed among all those fragments that are involved. You get callus formation and subsequent healing. Here again are some non-surgical options for fractures. Although many fractures do require surgical intervention, there are still a few fractures in the body that can be treated non-operatively. We can brace them, sling them. We can put a cast or a cast brace, such as a Sarmiento, or even boot stabilization for many lower extremity injuries. Around the upper extremity, still, there are many fractures that can be treated non-operatively, such as around the shoulder girdle, whether that be the proximal humerus, the scapula, or the clavicle. Isolated humeral shaft fractures often can be treated non-operatively. Isolated ulna shaft fractures, certain distal radius fractures that an anatomic or acceptable reduction can be obtained closed and maintained closed, and then many hand fractures. In the lower extremity, although most tibia fractures these days are probably treated operatively, there are a select few, depending on patient characteristics that we will discuss later, may be better suited to closed treatment. And again, once or if an anatomic or acceptable reduction can be obtained with a cast and maintained with a cast, then closed treatment for a tibia fracture may be completely appropriate. There are certain stable ankle fractures, if not all, that can be treated non-operatively as long as they are closed. And then many foot fractures can be treated non-operatively as well. So where does low intensity pulse ultrasound come into all that we've been talking about in terms of fracture healing? Well, I think it's important to understand the mechanism of action that lipus creates. So if you remember Wolff's Law, which was first described in 1892, bone remodels in response to mechanical stresses it experiences. The body will adapt to create an anatomical structure that's best able to resist the applied load to that particular bone. And I think we've seen that in all patients as they get older. You get patients that get knock-kneed, some patients that get bow-legged. And again, that's all due to various stresses their body and bones have been undergoing through various times. So ultrasound technically is a mechanical stress. It is an acoustic pressure wave that can be applied to provide a mechanical stress to the fracture site to help aid in healing. So we know from various studies that applying ultrasound, and again, looking at this both in a kind of laboratory situation, it can help improve the mechanical properties of bone. And it does that by not only increasing the bone density, but increases the collagen cross-linking as well as the collagen alignment. And it also helps to increase the porosity of bone. So obviously we would like to improve the mechanical properties of bone during fracture healing. And that's one thing that ultrasound can provide, especially when we're talking about in fresh fractures, which you will hear about later. So if you look at the mode and mechanism of low intensity pulse ultrasound in fracture repair, that is done by this study by Harrison et al., you can see the transducers applied to the tibia fracture here. This provides nanomotion because, again, if you remember, the transducer is applying acoustic pressure waves. So there is some micro or nanomotion occurring at the fracture site. That nanomotion is detected by integrins, which help stimulate callus formation. There are reactions of the cell on a cellular level, which increase COX-2, which help promote activation or formation of prostaglandins, specifically PGE2, and that helps increase fracture healing factors such as BMPs, VEGF, and other such factors. And this hopefully will give you a clinical response for enhanced endochondral ossification by helping to promote fracture healing or fracture callus formation and eventual fracture healing. Same studies in a schematic at the cellular level is seen here. Again, first thing is the pressure wave in the tissues, marked here. And again, integrin is detected or activated. That results in a signal activating receptors. There's also other signaling pathways activated in the cell. And then genes are turned on to transcribe COX-2 from the nucleus. That helps create more COX-2 enzymes, which are constructed by the ribosome at the cellular level. And then prostaglandins are then produced, giving you that clinical effect. Further delving into the mechanism of action for ultrasound, you saw two nice figures that kind of show you schematically what's going on. Now, if we look at it from a phase standpoint and isolate the inflammatory phase, that's where we see this upregulation of COX-2 that was shown in the schematic before. So again, that upregulation of COX-2 occurs early in the inflammatory phase when you're doing this for fresh fractures. That can increase the prostaglandin content. This also can increase aggrecan and collagen. And remember that initial nanomotion that occurs is detected by integrins, which is formed by osteoblasts. This also can inhibit osteoclastic activity, which is crucial early on, whereas increasing osteoclastic activity later on becomes more important in the other phases of fracture healing that we discussed. So if you look at the effect on angiogenesis, which again is crucial because we need a good blood supply to the fracture site, this helps promote expression of messenger RNA for angiogenesis. And you have an increase in these particular fractures. Most everybody is familiar with TGF beta. You may not be as familiar with VEGF or platelet-derived growth factor. Both have been shown to also be important for fracture healing. And when you have the application of the ultrasound to this area, you get an increase in all three of these hormones, which again is a direct result of that increase in COX-2 and prostaglandin production. And hence, hopefully you have an improvement in fracture healing. So that ultimately, and all these other effects that we've talked about, have an ultimate effect on callus formation, which is also contributed by an upregulation of aggrecan. And as we mentioned before, although initially in the inflammatory phase, there may be an inhibition of osteoclastic resorptive activity, as you get more osteoblast involvement and more stimulation, realize they kind of go hand in hand in that you get an increase in osteoclastic resorptive activity in that bone remodeling phase because they do go hand in hand. Other mechanisms are multiple cellular signal pathways that are activated. Some of you may be familiar with rankle, and this allows for activation of both osteoclasts as well as chondroclasts for resorption. So when you have ultrasound applied, you get an increased expression of this particular item, and that results in more osteoclastic and chondroclastic resorption. There is also stimulation of these three particular cell signal molecules, CFOS, ERK, NFAT-C1. There's also stimulation of stromal cell-derived factor 1 pathway, which is extremely important because that helps increase migration of mesenchymal stem cells to fracture site, which in hope will increase the number of osteoblasts that form, and thus you should get an overall increase in osteoblastic activity directly at the fracture site. One interesting thing that had also been looked at was how ultrasound not only helps with bone healing, but also helps with wound healing. And in this particular study that was published back in 2004, they looked at ultrasound and what effect it had on skin fibroblasts in a laboratory setting. And they found that when you applied ultrasound or those acoustic pressure waves to skin fibroblasts, there was a promotion of DNA synthesis. It also induced proliferation of primary skin fibroblasts. And they felt that this was probably the molecular basis for the clinical finding that ultrasound could promote soft tissue repair. And realized that the proliferation of these skin fibroblasts also involved activation of beta-1 integrins, as well as these two signaling cascades, ROA-ROC and SRC-ERK, which helped also provide improvement in wound healing in these particular situations. So let's talk about clinical decision making in fracture management. As we mentioned before, there's patient characteristics, there are injury characteristics, and then the various variables of treatment options that we need to take into consideration when we manage fractures acutely. Obviously, one of the most important considerations are the patient variables. Age, which is extremely important, especially as our overall population becomes more elderly. More patients have osteoporosis, and we know what goes along with osteoporosis is poor bone healing. They have very weak tissues. They tend to get fractures more easily and thus don't have as good of a repair process as perhaps a younger patient. Additionally, those elderly patients tend to have more comorbidities. Diabetes, which is also a problem for bone healing, and that has been shown throughout literature. But they have other issues such as hypertension, atherosclerotic disease, which may provide poor blood flow to lower extremities, resulting in poor bone healing as well. A history of infection is also important to elucidate because if they've had previous fractures or previous infections in those areas, placing hardware in that environment can be problematic as well. We know that smoking has been a problem with the nicotine causing diminished bone healing responses. And honestly, and unfortunately, with the vaping that's occurring, that can be problematic as well. There are medications that can preclude bone healing. So I think it's important when talking to a patient about why they may or may not be healing a fracture is to really do a thorough review of all their medications. In addition, there are many vitamin supplements or supplement type of medicines that people are taking, which may have some effect on bone healing and other facets of their healing that need to take into consideration. And then most importantly, obviously, underlying physiology. And that really goes into their metabolism. As we mentioned with vitamin D, many of our patients are vitamin D deficient. And I would have to say in my practice, I would say probably about 80 to 90% of them have been found to be vitamin D deficient. Although we can't really correlate a direct effect of being vitamin D deficient and non-union development, I would say about 100% of my patients that have non-unions have been found to be vitamin D deficient. And at least in my practice, we've gone to high dose vitamin D supplementation along with calcium to try to help mitigate whatever effect vitamin D deficiency has been doing in terms of developing that patient's non-union. Obviously, the injury is also important as well. We know that open fractures and significant soft tissue disruption can have profound effects on the ability for that fracture to heal. And that's really related to the energy of the injury. Obviously, a slip and fall versus a high motor vehicle accident results in two different types of morphology of and that in itself can be highly problematic. As you can see in the images on your right, you have a highly comminuted tibia fracture, which has both soft tissue issues as well as bony issues. You see the one with the arteriogram showing injury to the arterial vessels in the lower extremity. That can be problematic when there's blood supply disruption. Bone loss, again, as we mentioned, as we kind of like to joke, the osteoblast jumping distance may be too great for the fracture to heal. So we know that bones do not like distraction whatsoever. It cannot heal large gaps, and every bone has kind of a critical size defect, if you will, that it may or may not be able to heal. And again, the location of the bone. The femur tends to have an extremely good blood supply around it. It is completely encased in muscle, and despite being an open fracture, many femoral shaft fractures will still go on to heal, as opposed to the tibia fracture, which again is only covered by muscle in about 2/3 of its circumference. And so, as you know, tibia fractures that are open tend to have more problems and delayed healing than other areas of the body. So that must be taken into consideration as well. And then the treatment variables. Again, this is what you as the surgeon or the treating physician is responsible for. So you want to get a anatomic reduction that may be in terms of length, alignment, and rotation. However, for articular fractures, you want anatomic fixation and absolute stability. And again, that type of fixation will also warrant how the fracture heals. Often we shoot for absolute stability, but perhaps the stability of our fixation that we attempted to achieve did not occur. And you may see signs of that where you get callus formation in what you felt was an absolute stability construct, or perhaps that construct was rigid enough for most people, but in some individuals that may be morbidly obese, that absolute stable construct ends up being relatively stable for that particular individual. Again, alignment is very important, especially trying to reestablish the mechanical axis in the lower extremity. The timing of fixation is paramount to prevent any wound complications. I think we all over time have gone to staged protocols for many lower extremity injuries around the ankles, notably the tibial plafond, where you want to wait till the soft tissue environment is such that operative intervention can be undertaken. Here on your right, you can see again intramedullary nailing. And if you notice, this was actually a segmental tibia fracture that we were able to manage with a single nail because the proximal one was non-displaced, and then the distal fracture was easily aligned and reduced and stabilized with an intramedullary nail. So this should go on to heal with indirect bone healing. And then the postoperative care is important as well. Obviously, we like to get a nail in long bones because it does provide a load sharing device, and thus many patients can start weight bearing immediately. Again, as we go back to Wolff's Law, bones like to be loaded. So we want the bone to feel stress as long as the hardware can handle it and allow that bony response to occur. Whereas in plate fixation, oftentimes we have to hold these patients back in terms of weight bearing because plates are designed to be load bearing devices. And thus, since they're on one side of the bone, they are prone to failure if early weight bearing starts and the fracture has not provided some healing potential to help aid in the weight bearing of that particular limb. So looking at fracture management, as we mentioned, you as a surgeon are responsible for the mechanical environment. Well, part of that is making sure that the fracture is well aligned. So as one of my mentors taught me, you always have to obtain the reduction and then you have to maintain the reduction. So obtaining the reduction can be done via non-operative manipulative means or operative means in terms of when we do surgery, but we then need to maintain the reduction. So if we're planning on treating a fracture non-operatively, such as in the humerus or even in the tibia, we know we have acceptable parameters that we can accept, if you will, and that may be treated in a cast or a brace. And as long as those acceptable parameters are met, we can continue closed treatment. Oftentimes, however, they require vigilance and weekly follow-ups to make sure that you haven't lost the reduction, because we know as fractures heal and as fracture healing subsides or the time after the injury occurs, swelling subsides, and thus casts and braces can become loose, and then you can eventually lose your alignment. So you have to be very vigilant in seeing these patients back if you are to treat them non-operatively. Obviously, operative-wise, you as a surgeon have to make sure that if you're going for absolute stability with plates, that you have excellent fixation. If you do it with a nail, which is usually relative, fortunately, long bones are straight and nails are straight. So you usually don't lose much alignment with those, but you as a surgeon have to make sure that you at least reestablish the length and the rotational alignment, as well as varus valgus, which can be malaligned in certain proximal or distal fractures of long bones when you have metaphyseal injuries. And then external fixations people can treat fractures to healing in X-Fix, and I'll show you one case of that. But again, you have to be very in tune to how to put these on and to make sure that you have a stable construct. It may not be absolutely stable, but you're trying to get a relatively stable construct, and that can be achieved with an X-Fix. So looking at the various types of fixation options here, again, you have your K-wires from the least stable to plate fixation to your most stable. And this also goes with less biological damage. Obviously, putting a K-wire or even an X-Fix does not require large incisions. There's point contact where the pin or the X-Fix pin contacts the bone, and that's really the only place where you have disruption of the blood supply. Again, intermediary nails are placed in a very relatively minimally invasive fashion, as are bridge plates to a certain extent, depending upon how you apply it. These can be placed with minimally invasive incisions, placed submuscularly, and then affixed to the bone through small stab incisions, whereas oftentimes articular fractures require large open reduction for direct visualization of the articular surface, anatomic or absolute stability of the joint component, and then plates are applied on top of that. And that can result in much more soft tissue disruption. Here in this particular example is a case of external fixation, which again has limited effect on blood supply. There's disruption by pins only. It does allow for interfragmentary motion, so you get that callus formation. It is a relatively stable construct, and again allows indirect bone healing with callus. So this was a girl that was injured when she was at a ski ranch learning how to water ski. So you can imagine that the environment that she injured this in was probably not the best. So it's a water injury. It was an open fracture. There was about a grade 2, so you know you have soft tissue disruption. And one of my partners was on call and opted to basically bridge it with a external fixator, but it was more of a monolateral fixator, which certainly was not a very stable construct and was just done in a attempt to stabilize it to allow me to come back and do possibly an IM nail or something else. However, because of the environment that the injury occurred in, I was a little uncomfortable changing it out to an IM nail, just because those water injuries can be somewhat filthy. And therefore we switched it to a circular fixator, which you can see in the bottom left. You also can see, if you look at that area right at the fracture, and let me highlight it for you right there, you can see this callus formation that's occurring. So again, this is a relatively stable construct, allowing for indirect bone healing. And final follow-up films on the right there, you can see that she went on to heal that, had the external fixator removed. You can see where the fracture had healed anatomically. Although the fibula is not 100% well aligned, that's really inconsequential, and we had an excellent result. When you do intramedullary nailing, as you know, reaming usually occurs, and that can disrupt any medullary vessels. However, as many studies have shown, you get an increase in the periosteal blood flow to really make up for that loss of medullary vessel. But this does still allow for secondary bone healing. In this particular example here, the patient had not only a femoral shaft fracture, but also had a femoral neck fracture here that I think you can somewhat see. Well, the femoral neck fracture requires absolute stability, and thus was treated with this dynamic hip screw construct. And the femoral shaft fracture was treated with a retrograde nail. And you can see that is relatively stable construct, allowing for fracture healing with callus formation, whereas you get primary bone healing with the dynamic hip screw construct. Plate fixation. Here's an example of a somewhat extra-articular distal tibia fracture, and we treated the tibial plafon with absolute stability with plate fixation. You can see the lag screws going perpendicular to the fracture plane, stabilizing that. And really the plate is used more as a neutralization plate to diminish any rotational forces on the tibia. You can see we kind of mixed fracture healing constructs here by placing an intramedullary screw into the fibula. And again, that would provide a little bit of relative fixation there, but it was more just to realign the fibula than anything else. So you can kind of mix fracture healing constructs as well, as we've seen in the last two particular examples. But most of the time we get absolute stability with plate fixation. But as mentioned previously, if you have a very highly comminuted fracture, bridge plating can be used, where you would just bypass all the fracture site itself and place a plate via percutaneous techniques and just bridge, if you will, the comminution, allowing for secondary bone healing. We can put plates on there, and oftentimes soft tissue stripping is needed, but over time we've learned to use more minimally invasive ways to minimize the soft tissue stripping, which again is counterintuitive to proper healing. And realize that where the bone contacts the plate, you can get some bone necrosis, which has also been of concern. But I think over time, with better implants and better techniques, plate fixation still is an excellent way to fix many periarticular fractures. So in summary, bone is a living tissue, as we saw. It's predominantly comprised of calcium, as well as required for calcium and phosphate metabolism. Vitamin D is a very important facet of that metabolism, and I would encourage you to always evaluate the vitamin D levels in your patients, whether it be for fresh fractures or in these situations of non-unions. Although we can't correlate it one-to-one, that vitamin D insufficiency or deficiency actually leads to a non-union, but I think it's in the patient's best interest to have them primed in the best way possible to make sure that they have adequate vitamin D as well as calcium. Additionally, nutritional factors need to be taken into consideration. If you look at fracture healing, it definitely occurs in distinct stages, as we saw. To get direct bone healing, you as the surgeon need to provide an absolutely stable construct, and that is usually with plate fixation. Realize that indirect bone healing occurs from relatively stable constructs, and as you can imagine, the spectrum of relative stability is much larger than that for absolute stability. You can obtain indirect bone healing from relatively stable constructs from just K-wire fixation, external fixation constructs, intramedullary nailing, or bridge plating. Also, besides operative interventions, we have non-operative options. And these, I think, are still good for certain fractures, especially in the upper extremity. I still treat a lot of clavicle fractures non-operatively. I still treat a lot of isolated humeral shaft fractures non-operatively. And that's still a great option for those particular injuries. We also saw how lipase works. We know that it stimulates all stages of fracture repair, with I think one of the biggest things being that it helps stimulate COX-2 production, and that obviously increases prostaglandin production, which has other effects. Remember, it also helps increase collagen and aggrecan. We also saw that it inhibits osteoclastic activity early in the fracture repair process. However, later, you get activation of osteoclasts and chondroclasts for resorption in the later phases of fracture healing. Another important facet is we saw how it increased angiogenesis by promoting VEGF, TGF-beta, and PDGF, and has other various increases in expression of cellular signaling. One of the other important things that ultrasound was found to do was increase the migration of mesenchymal stem cells to the fracture site, which overall would then increase your osteoblastic activity. And then I think another important finding, which was at least surprising to me when getting prepared for this talk, was how ultrasound stimulates wound healing in and of itself. We saw that helps increase the proliferation of skin fibroblasts and the other activities, and shows that it can actually help promote wound healing in and of itself. And finally, we looked at some clinical cases and looked at decision making for fracture management and realized that it is entirely multifactorial. You have to take into consideration the patient, the injury characteristics, and again, I think we need to take into consideration our own abilities as a surgeon and what we can or can't do. And I think by taking all of these things into consideration, we can do the best thing for our patient and also understand that lipus may have a place in our overall care of the fracture patient. That's the end of my talk. Thank you for your attention. And now we will be going to the question and answer session. Thank you once again. Good afternoon. Thanks for joining us. I hope that was informative. If you have any questions regarding my little talk there, please submit them and I'll try to answer them as best I can. While we're waiting for some questions, I think a couple of questions that always come up are regarding really vitamin D and the role in fracture healing. And I think most of us realize that these days, most of our patients are all vitamin D deficient. And so I know I've checked my vitamin D and I'm pretty low. And so I'm on replacement as well. But I think although the data is not there, for sure that vitamin D is necessary or is needed in terms of supplementation. Most of my non-union patients that I deal with will get checked. And I can tell you that probably 9.9 out of 10 of them are all vitamin D deficient. So I'll make sure I start them on that. And then I will start them also on calcium. So I think it's important to remember to have both vitamin D as well as calcium when you give these patients. And as far as the dosing goes, I'm pretty aggressive. I'll give them 100,000 units weekly. And there's been some nice studies showing that that is completely safe. Nobody's ever had issues from hypervitaminosis D. And at the Academy, there's a nice safety paper on that. We do have one question. One is, do you start lipus on all open tibias or some? At least in my practice, a lot of it has to do also with being able to get it covered. So if I can get it for them on an open tibia and they have other confounding variables such as they're smokers or diabetics, then I try to get it for them earlier. Unfortunately, sometimes that's not that easy to do. As far as medications seeing inhibit bone healing, that's a great question. I think it's hard to know just because I don't think we're really good about being able to decipher what medications people are on and how that actually inhibits bone healing. So I can't say that I've ever can correlate one-to-one on a particular medication that a patient of mine is taking. As far as the vitamin D level of 20 versus 30, I mean, honestly, most of my patients I see are all less than 30. I try to get them up in the 50 to 70 range. The other thing I would mention is if you do get a vitamin D level and it's extremely low, I usually concomitantly get a PTH level. You'll find that a lot of these patients actually have secondary hyperparathyroidism, and I end up resolving that as long as you get them vitamin D replacement. Let's see, I have another question. Is a fracture code enough to get vitamin D lab covered, or are you seeing patients being billed for this testing? I have not heard of any problems, at least in my area, in terms of getting a vitamin D covered. No one's complained about getting billed for it. So as far as I know, I think it is getting covered. Another question. NSAIDs and acute fracture. How do you balance pain management versus avoiding suppression of bone healing? So that's a great question. I think a few years ago, we were all very kind of concerned about giving patients NSAIDs. And I think a lot of those studies have really turned out to be really not true in terms of bone suppression or bone healing suppression with NSAIDs. And so during that time where we probably, were preventing them from getting, post-op Toradol, naproxen, ibuprofen, we've kind of gone away from that because really the studies have shown that it really doesn't affect it. I think some of the early animal studies did show that there was concern of NSAIDs preventing fracture healing. But at least in my practice, um, pretty much that's part of their mainstay post-op pain protocol, especially in this day of all the narcotic control that we're having. So it is a great question, but I don't think we're seeing the issues that those early animal studies were indicating. Great questions. Hopefully, some of you will have some other ones. In the meantime, I know you've heard from some other speakers today. I think one question I don't think anyone asked it earlier is if ultrasound does provide a benefit, why not more than 20 minutes? I've had patients that have wanted to use it 2, 3, 4 times a day, and really that's based on a lot of their basic science research that they did, that the maximum activation of those the cellular signals that we talked about really get maxed out after 20 minutes, and they stay kind of elevated, or that signaling stays activated for a full 24 hours. So you can't stimulate the cells anymore despite doing it 2, 3, 4 times. And so at least from a basic science standpoint, 20 minutes is more than enough of doing that. And the other really the downside is, the units that you get are really designed to give X number of treatments. And so I've had a couple of patients who, after 1 or 2 months, are like, my unit's not working. And then when I start talking to them, I find out that they were doing it 2, 3 times a day. And so the unit will run out. So, I tell patients really just once a day is enough. Um, let's see. Yeah, please send some more questions if you have them. Another, thing that it's important to look at. I do a lot of non-union work, and so obviously that's a cessation of fracture healing. And so one thing I can't stress enough is to fully evaluate the patient and their metabolic capabilities of healing a fracture, because regardless of what you do, whether it's surgically, whether it's throwing a stimulator on, I think they still need to have their metabolic workup done. And at least at my place, we tend to do that. We don't have a lot of endocrinologists around. And most of it is basic. And most of it, again, goes back to vitamin D, or poor glucose control with their diabetes. So we end up doing a lot of that in terms of evaluating their hemoglobin A1C, seeing what kind of control they've been having to make sure that that's not an issue. And then obviously smoking. And some of the studies may be, not 100%, but I do believe that smoking does have some hindrance in terms of getting the fracture to heal, if we can get them to stop smoking. One question is, what units do you like? I'm sorry, could you clarify in term units? Are you talking about vitamin D dosing? I do 100,000 units weekly, and I'll do that for a good 6 months. And I've never had anyone have any issues with that. I used to do 50,000 units, but there was a nice paper presented at the OTA a couple of years ago that showed, in terms of vitamin D response, 100,000 units weekly seemed to work the best. And then again, to reiterate, there was a nice safety paper that was done and presented in a poster just this last Academy a couple of weeks ago that showed 100,000 units was completely safe. And then as far as calcium, which again, I failed to mention the dosing, remember that the dosing of calcium should be about 800 to 1,000 milligrams a day, versus the vitamin D has to be weekly. As far as equipment, I guess in terms of ultrasound, we tend to use the Exogen unit. And remember, you have to differentiate between electrical currents or inductive coupling, or capacitive coupling, and ultrasound. Those are probably the 3 types of bone stimulators that are out on the market. I'm preferential to ultrasound. Anyway, barring any other questions, I want to thank you again, and please enjoy the rest of the webinar, and you should have the next speaker coming up shortly. Thank you again for your attention, and have a great day.